This film will cover the activity and adjustment of pacemakers. What's important to know is for temporary pacemakers, there are 3 obligatory names. The first spot refers to what is being paced. The second spot refers to whether there is sensing going on. And the third spot refers to what is the action if there is something that's being sensed. And by sensing, I mean the pacemaker's electronics ability to sense whether there's an activity within the chamber that's being paced. And that's important because if there is some sensation of native activity, you don't want the pacemaker to pace ideally. You want it to not pace. And so for the first spot, as far as pacing, your options are apacing, ventricular pacing, or dual chamber pacing. You have 2 sensing options depending and regardless of where you're being paced. And the nomenclature here is either to sense the ventricle if you're pacing the ventricle, sense the atrium if you're sensing the atrium, sense both chambers if you have a dual chamber pacemaker or dual wires, or don't sense anything at all. O. Action is to do nothing at all. That is, if you have no sensing, there's no action that's going to happen. Or rather, no inhibition of action. There is I for inhibit the activity of the pacemaker itself. And then there's D, which is kind of like dual function, which means basically inhibit if you sense atrial activity and inhibit if you're sensing ventricular activity. So type of pacemakers or type of settings that you'll see would be AAI. So that's an atrial pacemaker that is looking for atrial activity, and if it senses it, it will inhibit it. There is AOO, and these aren't type of pacemakers. These are modes that you're actually dialing into the box. And that is something that is just basically pacing the atrium at your set rate. It's not sensing, and because it's not sensing, it's not inhibiting. So that's AOO. You can have ventricular analogs, VVI and VOO. Sometimes the inhibitory, when you have like sensing and inhibition, this is sometimes called demand pacing, which means if there is nothing going on, then the pacer will pace on demand. And situations like AOO or VOO and DOO, where you're just pacing, period, and you're not trying to sense anything, and you're not going to do anything because you're not sensing anything. This is also called asynchronous pacing. And finally, to round out our list, we have the dual chamber analogs of these. DDD means you're sensing both atrium, meaning you have actually atrial and ventricular wires. You're sensing both, and if there's an atrial impulse, it'll inhibit. And if there's a ventricular impulse at a certain interval and rate, that it will also inhibit. And then finally, there's DOO. So for the first example, to discuss the settings, we'll take kind of the most basic scenario, and that is when you have someone that's just asystolic. You pick the clinical situation, coming off bypass, someone who had a massive efflux of potassium, you name it. And so you manage to have a V wire in. And so basically what you want to do is pace the patient at a rate that you consider compatible with life. And so if it's just a V wire, what you can do is just set it to pace at a rate of 60. So every second, the pacer will go ahead and pace. And let's say that is a VOO situation. You're starting out with a flat line. You just want to have paced beats, period. Totally reasonable strategy. The problem is if the patient's own heart rate comes back and, let's say, generates an impulse within this window here, and you're not sensing that beat and you're pacing on top of it subsequently, you can get a torsade situation, which is not very good. So your safeguard around that is to have the patient paced at VVI with the understanding that you're completely overriding things to begin with, but you expect some activity to come back and you don't want to create some kind of R on T phenomenon. Okay, now we'll consider a situation where you have both A and V wires placed in the patient. Let's say this is a patient that you're worried about AV block in, or maybe they have left ventricular hypertrophy and you really want to get a good atrial contraction coordinated with a ventricle. So your settings in that case, you're going to, so if you're doing AV pacing, your settings are going to be not only your A output, also your V output. You're also going to program an AV interval, which is quite important. And you also have to go ahead and think about the atrial and the ventricular sensitivities to see if those are appropriately set. Most of the time the defaults are okay for sensitivity, but sometimes it requires a closer look. And so let's again say that we're going to pace at a rate of 80, and so, 60. And so every second, what's going to happen is, in this case, the atrium will pace if there's no atrial activity. And then depending what you set your AV interval at, and let's say that that's 200 milliseconds, once 200 milliseconds transpires, if there's no ventricular activity sensed during that interval, you'll go ahead and pace your ventricle. And then 1 second later, again, if there's nothing sensed in the atrium will pace, and again the ventricle will pace if this interval is exceeded. So let's say that you have a first degree AV block that resolves, but you still have sinus bradycardia, so your AV pacing here, sorry I'm kind of scrunching these intervals here, but now you're A pacing there, and actually that's conducted, and so then you go ahead and you get a native ventricular beat. And so this would be called A sensing, sorry, it's wrong, it's called A pacing, and V sensing, because the ventricular doesn't need to be paced. It sensed something that was going on. The native activity was adequate, and so the pacer basically stood there on standby and didn't do anything. And so you can imagine kind of a combination of pacing events can happen depending on what your native sinus node rate is, what the degree of AV block is, and how you're kind of working with the patient's own native conduction and native rate and having your pacer respond accordingly. What you don't want to have is if, let's say, you unplug your pacers temporarily and you see that you've got decent AV conduction, normal atrial and ventricular activity, and this is, say, at a rate of 55, then you don't really want to have your pacing going at 60, because you're going to get some native slowing and speeding up, and you're just going to have the pacemaker and the patient compete with one another. So in this case, what you want to do is just see if the patient can actually have a decent cardiac output and blood pressure at their own native heart rate, and then either kind of go high or go low depending on what you find. And so if it's a pretty low cardiac output, a pretty low blood pressure, then go ahead and make your pacer go at something like 70, 75, something just above what the patient's own rate is. And that way you won't create too much confusion, you won't create any RONTs, and probably have a lot cleaner setup. So let's take a look at another scenario with AV pacing. You get called to the bedside, and the nurse is concerned because the patient that once had a MAP of 68 has now dropped to 58, and the cardiac output that was once 6.2 is now 5.1, and now the heart rate that was once 65, which was basically normal sinus rhythm, is now being paced at 60. And so you're taking a look at what's going on, and what you see is basically A pacing and V pacing. And your pacer is set once again at a rate of 60, and the PR interval that you have set is 180 milliseconds. So the question is, what do? You're watching this patient kind of chug along, being completely AV paced every second with a lower cardiac output, lower blood pressure. Well, there's no right answer, but one thing you can do is ask, what is the patient's underlying rhythm and rate? And so what happens when you go ahead and just pop those little connectors out of the top of the pacing box, you see that actually the patient's heart rate, patient has, some AV block, but their native heart rate is around 56. And it turns out to be that with 56, their cardiac output is actually a little bit better. It's 5.8, and the MAP is actually a little bit better. Instead of 58, it's now 63. And so it looks like, despite this lower heart rate, that this patient's actually doing better. And, is the patient doing all that well? Well, they're a little bit sluggish there. Get that. But the key thing here is that probably there's something about just the patient's own native conduction that's a little bit better. And that's actually a pretty common scenario, especially when you have a hypertrophic ventricle. It just turns out to be that rather than having a pacing impulse spread through muscular tissue, have anterograde AV conduction, where the impulse is going down a neural network, and you have a very coordinated contraction of the ventricle. It's quite orchestrated. It starts in the apex and kind of has this screw motion upward, that you actually get a better stroke volume. So, the question is well, where do you go back to if you want to try to make things better with pacing? So we'll give this one a fresh start. So you've disconnected the pacemaker, and you've got this heart rate. I guess we decided it was at 55, slow sinus. Well, one thing you can do is go ahead and try to reconnect the pacemaker and go up on the rate to 75 and see what happens. And so now you're actually being A-paced, and it turns out to be that you're also V-pacing at 75, and I won't bother drawing that out. And again, this is call this scenario A, and this one B And with A, the cardiac output, I think, went to 5.8. And the MAP went up to 63. And now in scenario B, despite the faster heart rate, the cardiac output is somewhat lower and the MAP is somewhat lower too. So obviously this heart didn't read the textbook that heart rate times stroke volume is equal to cardiac output, and that brings your blood pressure. Well, actually maybe it did. It just turns out to be that your effective stroke volume is not the same when you're paced as opposed to having native anterograde conduction. So how do you work with anterograde conduction when you know that it looks pretty decent here, but at the same time, when you crank up your pacemaker rate, you're really not getting it here? Well, there's a couple options that you can do at this juncture to improve the situation. One is completely take off the V wire, and so again, this is no pacing here, and this is in a DDD mode. So one thing you can do is go to an AAI mode, which means that, and let's just say this is at a rate of 75 once again. So you're pacing at a rate of 75, which is faster than the native rate of 55. So no surprise that that is that you're going to be apacing there. But because you don't even have any ventricular wire hooked up, you're going to get good old native anterograde conduction, albeit at a prolonged PR interval. And just for sake of conversation, we'll call this scenario C. And let's say scenario C actually is giving you a better cardiac output and a better blood pressure. So that's probably where you want to work with. You probably want to work with just increasing your atrial rate, getting anterograde conduction, letting the ventricular depolarize and contract in a very natural way, and get a better stroke volume that way. And you can play with the rate here depending on what you think the patient does need for cardiac output or blood pressure. So what other option do you have? Well, you can go back to DDD, but in this case, go ahead and see what the patient's native AV interval is. And let's just say this 200 milliseconds, and your prior DDD setting was at 180 milliseconds. And so what you can do is you can go back, put your V-wire in, which is kind of a nice thing to do for safety. In this case, go DDD at 75 with an AV interval of something greater than what the patient's doing, say 220 milliseconds. And so if nothing happens here after 200, it'll wait 20 milliseconds further in this new configuration and go ahead pace there, which is kind of a nice thing, because if your AV block gets totally out of control, you want that to be working for you. And in which case what you're going to get is something that looks very much like this, very much like scenario C, where you have draw the pacemaker artifacts, where you have A pacing and V sensing. So you have paced A beats and then native QRS. And again, that's going to give you, when you bother measuring it, it's going to give you similar cardiac output and blood pressure. Okay, we'll consider one final scenario. Let's say there's a patient that has had a cardiac arrest. They're horribly bradycardic, ventricular escape rate 30-ish, nice and low. So you float a transvenous pacemaker and pick a mode. And so in this case, it's going to be either VVI or VOO. Sometimes in desperation, people go with VOO just to make sure that you're absolutely capturing. Actually, it turns out to be that on the Medtronic dual lead pacemaker boxes that I showed you, the default is DDD at 80. And so if you're plugging in only the V lead rather than two leads, this is going to be VVI. Or if you're only plugging in on the atrial side, it's going to be AAI. So being a lazy person, that seems a little bit dangerous, and that can wander into some trouble. I think just plugging in the ventricular side and going for VVI seems perfectly reasonable. And so that's what I would recommend. And so in this case, what you want to do is not really think so much about, well, does the patient do okay at 55, 60? You want to go for something pretty darn fast, so you just absolutely know whether you're taking over the pacing on this heart or not. I usually go like 80 or 90. I mean, these are desperate situations. And so we will go ahead and put this pacer in, and you float it in with the balloon, and eventually you'll touch part of the ventricle, and you might get intermittent capture and then a little bit of release. You're going to deflate the balloon, and finally you want to just kind of get it nestled in there in a location where you don't have to use the full 20 milliamps output on the atrial side. You want to have a little bit of safety, and so you want to kind of test your thresholds once you get in. And so what you'll do is what it's going to look like is this. You're just going to be cranking along at a rate of 80. If I can get this thing to wake up. Which is totally fine. And you're going to be, and actually the heart rate, the pacemaker really isn't even going to be sensing these beats, because you're going to be basically taking over all the rate and refractory period, and probably these impulses won't even be generated. But let's say somewhere along the line, while you're pacing at 80, you go ahead and see what the milliamp output that you need is. It turns out to be that you can capture it only 3 or 4 milliamps, which is pretty darn good for a transvenous pacemaker. And so you double that, make it 8 to 10, a little bit more than double. And then what you notice is that you back off, let's say you back off the pacemaker now that you get the patient back to a reasonable blood pressure. Things have settled down after a while. You're going at a rate of 60. And then all of a sudden what you see is, right when the pacer should be sensing and inhibiting, if it senses something going on with the native heart actually does go ahead and beat and generate an R wave, but then boom, the pacer paces right on top of that. And so that shouldn't happen if you're in a VVI mode. And so what you really have to look at in that situation is whether your pacemaker is actually properly sensing. And then what you want to do, especially if this is a recurrent problem where you're, looks like that your pacer is pacing on top of native ventricular beats or slightly after, which is incredibly dangerous. You want to go ahead and take a look at that sensitivity and make sure that it's properly set. You might have to turn up the sensitivity some, and in doing so, you're pretty much back to normal. Then that's your answer. Sometimes if doing that does not remedy the situation, sometimes just batteries at the end of their lives can do this, and these are just simple 9-volt batteries in the pacemaker. Best thing to do is just get another box and pop it in place while you figure out what's going on with the battery of your first box. You can test them out by just touching them to your tongue, and if it zaps it really, really hard and you can't hold it there for more than half a second, chances are the battery's pretty good. But if not, you might have to refloat your pacemaker and make sure that it's capturing appropriately. And this applies for both temporary pacemakers as well as epicardial leads. Usually you have pretty good connections on epicardial leads, so you don't have problems with sensing, but it is a possibility. Okay, so to summarize, hopefully the scenarios that we talked about cover some of the adjustments and settings that you will make on the pacemaker, and in doing so, really get to kind of the core things that are important in assessing these patients and assessing their needs relative to pacemaker. So to summarize, or just to review, the most important thing is just when you come upon someone that's riding a pacemaker, they could be hemodynamically stable and it could be totally fine, but you got to understand, what is their underlying activity? Are they just a slow patient that's being paced, or are they really pacer dependent? Is the underlying rhythm asystole or something dangerously low, either with high degree heart block or just a very, very slow ventricular escape rhythm? If that's the case, you have to just stop right there, and you got to make sure you have a backup pacemaker in the patient's room, make sure the battery is good, and make sure there's an awareness of all the people taking care of that patient that that's pacemaker dependent, that you don't do some kind of amateur experiment or maneuver when you wouldn't if you actually knew the patient's pacemaker dependent. And then, again, depending on what's going on with the patient, that patient might need to be on the fast track to get a permanent pacemaker. Or is it something like edema that, might resolve in a little bit, or some electrolyte disturbance? But absolutely got to know that. Along the same lines, is when you're looking at the patient's rate and whether they're dependent or not, is try to get a sense of what the AV interval is, especially if you're dual chamber pacing. Try to get a sense of what your pacemaker setting is versus what the native AV interval is, and in doing so, try to really figure out what is the best for the patient. What do they like the most? Some people like high heart rate, some people like low heart rate. Some people could care less whether they're getting anterograde conduction or whether they're being V-paced. They just need a heart rate. And then some people really perform a whole lot better if they have native AV conduction. So being able to identify that is going to help you figure out what to do as far as pacing the patient, dual lead pacing, how you want to set the AV interval. Do you want to set it so the patient can conduct on their own, or maybe their own native conduction is just so darn slow, you're better off AV sequential pacing. There's no textbook answer to any of these questions. You have to individualize therapy. It depends on the patient's heart morphology, thickness, what's going on with them, what the nature of the surgery is, other characteristics of the heart. So hopefully that'll give you a few pointers to get you started. Main thing is if you're kind of a neophyte here, don't get too far along if this is the problem here. Identify that they're pacer dependent. Don't spend too much time in asystole. Get into the bottom of it. Make sure there's an awareness. Make sure you've got a backup plan, because that could be pretty dangerous. Well, that's all for now. Thanks for your attention.